Welcome to Casual Conversations. This is hosted by IBIA and NABIS. I'm Katherine Snedaker of Concussions, and this is our 39th week of bringing you experts in brain injury to speak about issues that professionals and patients can take some information away. So I'm very happy to have Jacqueline Theis back on the show. Welcome, Jacqueline.
Hi, how are you?
You were a very popular speaker last time, and it was really great to talk to you. And we had a lot of questions that we didn't get answered. So thank you for coming on again.
Sure, absolutely.
I did want to review just a little bit how you got to where you are today, if you want to share your story that connects you to this space.
Yeah, I'd love to. So my background started out in sports. So I was a competitive athlete. I played competitive soccer and snowboarding. And as a kid, I accumulated a lot of concussions. And at the time, unlike now, where if you suspect a concussion, you pull them from play. Essentially, if you could say the alphabet backwards, they'd let you go back in. So I ended up getting, by the time I was maybe a sophomore, junior in high school, I had about 8 concussions under my belt. And I just had terribly debilitating headaches and I couldn't read. And I went to every neurologist and every ophthalmologist and was put on all these medications and tried all these treatments, and nothing really happened to make them better. And so they essentially kind of just said, you can't play your sports anymore and you just have to wait it out and it'll get better. And so I waited. I went to college. I went to Bucknell and I was pre-med. And during the pre-med track at Bucknell, we have to follow different physicians to see, what type of physician you might want to be. And I was following an optometrist at the time. And the optometrist didn't have a patient when I went to follow her. And she said, well, why don't you take a seat and I'll do an eye exam on you? And I had never had an exam from an optometrist before. I was that 2010 athlete that didn't need glasses. And immediately, within a few minutes of the exam, she goes, have you ever had a head injury before? And I said, yeah, how do you know? And she goes, because your eyes don't cross at all. And so there's a test called the near point of convergence. So most people should be able to cross their eyes to about 5 centimeters. And I couldn't cross them past 40. And so she immediately knew that I had trouble with my eyes in an atypical way. And she gave me prism glasses. And the prism glasses were great. They're not a fix for convergence insufficiency. And we had talked about this last time. They're definitely a Band-Aid, but they're a Band-Aid that gave me endurance. So I went from only being able to read from 5 minutes to an hour, which in college is huge, especially when you're pre-med. And my headache started getting better. So go ahead.
For 1 second, you saw an optometrist. Can you explain the difference for somebody that walks into like an eyeglass store and wants to get fitted for contact lenses? What type of doctor are they seeing then?
So if the doctor is fitting contact lenses, they're usually an optometrist. I have yet to see an ophthalmologist in one of those stores. And so there's 3 big differentiations that can be confusing for everyone. So there's an optician, an optometrist, and an ophthalmologist. So the optician is the person who is always going to be in an optical. They're going to help you fit your glasses and make sure they're adjusted correctly. And then the optometrist is a primary eye care doctor. So they do the glasses and contact lens prescription, but they also do an evaluation of your ocular motor health or ocular motor system, your eye health, your glasses and contacts. So think of them kind of like your primary care physician, but for the eyes. So an optometrist, after we go to college, you go to optometry school for about 4 years. And then some of us do an additional residency. So you can be a resident in pediatrics, you can do neurooptometry and brain injury like I did. You can do double vision, eye turns, things like that. And so that's additional training you can get on top. So even within optometry, you have some subspecialists within the group. So not every doctor is going to be the same.
Now, if you're going to an eye doctor and you've had a concussion or you're questioning some of this, could you go to your regular eyeglass store and ask, for a convergence test?
Yes, you can ask. I sure hope they can do it. Oh. I really hope they can do it. Unfortunately, everyone does their exam differently. Everyone does their screening exam differently. And for for me, what's so important with convergence is that the type of tests you do matter. And that's where being a subspecialist in the area is really what ekes itself out. Because if you do a near point of convergence test where, so imagine, right, it's done on the sideline a lot, even by sports med physicians, where they just have you follow their finger as they bring it towards your eyes. But the size of the target matters. So sometimes if you use a target as big as your finger, the eyes can actually cross with that target. And so you'll miss a convergence problem. Because if the target were smaller, like say a reading size font, actually you'll notice there is a subtle eye turn on smaller things.
And when you're trying to focus on a text, it's a smaller item that you're focusing on than if you were reading a font size, the size of the point of your finger.
Exactly. And then the speed matters, right? So if someone's going too fast, you might miss it. So as we know with brain injury, we can have slowed visual processing speed. So if it went double 25 centimeters from my face, but it takes my brain some time to say, hey, it went double, and me to spit out loud that I said double. If that target's still moving towards me, I might say it went double at 5, but really it actually went double at 20. It just took me time to let you know. And so that's where there are nuances where they can be easily missed by someone who doesn't do it a lot. The other problem too, and convergence is great because a lot of people are starting to look at convergence for so many reasons. But as an optometrist, what we've been finding is a lot of patients who have convergence disorders after a brain injury may not actually have a convergence problem. It's an easily screened problem, but they might actually have a problem with their focusing system or their eye movements, like a saccade. And so their convergence is definitely reduced, but it's not the true problem. It's kind of like the symptom. And then the point of going to a specialist is to figure out is it truly convergence insufficiency, or what we call a pseudo CI, meaning it looks like a convergence insufficiency, but it's actually something else completely.
I think that's one of the problems, especially when parents call, they said, well, I went to the eye doctor, they say there isn't a problem. And then you're trying to figure out, did that doctor look for issues around something that you'd see in a concussion? So is there something that if you're calling for this, that you would specifically, like, do you have experience with a concussion? Because that for a while, that was tough to find around here 10 years ago.
It's tough to find now still, I think. And I think there's also something to realize as well. So one is training. The research coming out on concussion and eye movements is in real time. So if you're not invested in this and reading the literature as it comes out, you're going to miss it, especially if you were trained decades ago, when decades ago, number one, we didn't know that this was so common. Number two, we weren't looking for it, nor knowing how to look for it. And then, of course, we didn't know, even 5 to 10 years ago, we weren't actively treating it the way we are now. Now we see it and we start you on treatment right away. Before, we used to just watch and see if it would get better. So even our treatment paradigm has shifted so rapidly. The other problem too, and it's a good thing. So I often encourage people to get their eye exam before they see me. For one reason is the typical eye exam is a structural exam. Is the eyeball okay? We need to make sure the eyeball is okay. And then once the structure of the eye is okay, then the problem is usually the brain's coordination of how the eye works. And that's usually what goes awry in concussion. So I always tell patients, going to an eye exam and them telling you your eyes are normal is a great thing to have. The last thing we need is to have a brain injury and a retinal detachment. And that can happen. You can have a tear in the retina. You can have, all kinds of damage can happen to the eye if we get hit in the eye. So we want to make sure that's healthy. But once it's healthy, if it's normal, and you as a parent know that your kid is struggling visually or getting headaches and fatigue with visual tasks that's abnormal, that's when you want to maybe look for somebody who is a specialist in it.
And then in the research part, at what phase are they looking? I mean, Christine Masters doing a lot of chat, but what are they looking at, 3 months out, 6 months out? Where are you seeing most of the literature coming from right now? How far out?
Timeline to diagnosis?
Yeah. So what groups are being studied? Right after injury or the prolonged symptom stage?
So I think it depends what study you're looking at. So the studies range all types of timelines. So we know in an acute concussion, some of the studies that have come out in acute concussion, which most of them are defining as within about 1 to 2 weeks of the injury, we're finding about 80% of people are going to have an ocular motor problem, which is huge. I think that number astounded most of us when it first came out. Of that 80% normally will actually self-resolve within 3 to 4 weeks. So from the patient perspective, I always say, if it's still there for 3 to 4 weeks, but kind of every week you're getting better, I'm not too concerned about it. What we're finding in the long-term studies of patients with ocular motor dysfunction and post-concussion symptoms that are lingering is that if they're not better by about 4 weeks, they're likely not going to get better and they plateau. And the beauty of the eyes, though, is that just means they need rehab. We can rehab the eyes. And I've had patients who are 6 years out from their injury come in and we do rehab and they still get better. And the nice thing about the eyes, if it's from a concussion is a functional, as far as we're going to describe it right now, injury. So functionally, we should be able to get you better. And once you're better, you're better. It's not a lifetime of vision therapy for the rest of your life. Now, moderate and severe traumatic brain injuries where we've actually had structural damage, sometimes we can't get people back to their 100%. So for me, it's very crucial to know exactly how much of a brain injury, what level we're looking at, so we don't overpromise to the patient what we can do. But even I've had patients with severe traumatic brain injury and ocular motor dysfunction like convergence, where we used to just put them in Prism and say, good luck to you. And I do a lot of home-based rehab, so it's not going to hurt anyone financially at all. So I say, hey, give this a try. And my severe traumatic brain injury patients have surprised me time and time again where they get better. Maybe they don't get to 100%, but they get 80% better. I have one patient that always comes to my mind with this, where 3 years out by the time he came to see me, because he was in a coma for maybe 2 to 3 months after his injury, and he couldn't read at all. And he's aphasic and he also couldn't walk. And so there's a lot of reasons it took him a while to get here, because he couldn't say out loud, hey, I can't read. Right. And so, but what blew my mind is that within about a year, we could get him to read. Now, he still needed Prism, he still needed breaks, but we got him to do it. And for me, that's huge from a functional standpoint, is how can we get you back to do what you enjoy?
Yeah, and a quality of life to be able to connect and learn and on that, and print still on the internet to connect. So that's great. You had a slide that you wanted to share. Would now be a good time?
Yeah, that would be great. So I wanted to, there's 2 slides here. Let me screen share. And then give me a second. Let's see. So we'll screen share this one. And then wait for the current slide. And we're getting the beach ball of death from my computer. Give me a second. There we go. Okay, so do you see my common symptoms slide here?
Yes, definitely.
Okay. So one of the big things that I like to talk to people about with vision problems and concussion is that we do a really great job post-concussion of screening for symptoms. And so usually we'll group them into physical, mental, and emotional type symptoms. And normally the ones that I have highlighted on the red in the screen is what is going to normally be sent to an eye doctor. So double vision, blurred vision, light sensitivity, those ones usually are, hey, you should go see an eye doctor for this. But in actuality, when we look at visual symptoms in concussion, they end up being much more nondescript. So you can have dizziness, headache, balance problems, nausea, and fatigue that are actually caused from the eyes. You can have disorientation, trouble with concentration, mental fogginess, concentration and attention, loss of focus, nervousness, and anxiety from the eyes. And the beauty of highlighting this, I always tell people, is sometimes your eyes are giving you other symptoms that aren't typical eye symptoms. But if you actually get to an eye care provider and we can identify the problem and fix it with some vision therapy, your other symptoms go away. Now, not all anxiety is caused by the eyes. Not all mental fogginess is caused by the eyes. But if it is, we can fix it. And so that's always important to me. And the big question of how can the eyes cause all these symptoms? And that's where I like this following slide, is to understand just how wide of a network the visual system plays in the brain. So imagine for a second that a soccer ball moves in front of your eyes from the left to the right. The image of that soccer ball is going to be translated from the front part of the eye. That light signal gets focused onto the retina, and the retina takes the light signal and makes it a chemical signal. So when you're getting an eyeball exam, that's what we're making sure is still working. And then that chemical signal then gets transmitted down the optic nerve and goes to the optic chiasm. So we have two eyes, and at the optic chiasm, the two eyes share that information. And then they go to be minimally processed at the LGN. And what I mean by minimally processed is that the information gets sorted. And this is an important juncture from brain injury standpoint, because about 90% of the visual pathway information at this point is going to continue to the occipital lobe for visual information processing. So processing what we see. But 10% of the light information that we get from our surroundings actually takes a detour at this level of the brain and goes to the midbrain, the hypothalamus, and the thalamus for light sensitivity issues. So light sensitivity that we get from migraine, so photosensitive migraine, this is the pathway that it's going through. When we get sleep-wake cycle regulations, this is the pathway that it goes through. And that pathway is regulated by specific retinal ganglion cells that are triggered by blue light wavelength. And so I don't think we had time last time to talk about blue light too much, but with blue light has a function. It tells us when it's light and when it's dark out. And so a lot of times in concussion, people are wearing their sunglasses all the time. They're avoiding blue light devices because it triggers symptoms. And then they get all this chronic fatigue. They're all putting themselves in blue blockers, and they're messing up their sleep-wake cycle because their brain doesn't know when is it dark and when is it light out, because you're not letting it have that kind of circuitous rhythm of blue light exposure. So that's how the eyes can actually impact your sleep and brain injury, and how some of your environmental adaptations to feel better can actually prolong your prognosis and getting better. So going back to the pathway, the rest of the visual information gets to the back of the brain. So when you get an exam by an ophthalmologist or an optometrist, this is the main pathway is the visual information getting in. And if that's normal, excellent. Your visual fields are normal, your pupils are normal, your color vision is normal. And it's wonderful that that's normal, but that's not really how the vision is processed. So the vision got in, and then what happens is the occipital lobe organizes that information and it sends that information to the temporal lobe. And the temporal lobe is our what pathway, and it buds up to our language centers and our hippocampus, and it says, hey, this black, white, and round thing, we've seen this before. We call it a soccer ball. And so it kind of gives you some object recognition. And then at the exact same time, the parietal lobe is also getting visual information, but the information the parietal lobe gets is based off of spatial orientation. So I don't know what this black, white, and round thing is, but it's moving from the left to the right, and this is where it is located to where I am in space. And then the parietal and temporal lobe takes that information and sends it to the frontal lobe, which is your decision maker, and says, hey, if I want to follow the soccer ball with my eyes, the frontal lobe is what's going to actually initiate the signal down to the brainstem and say, hey, brainstem, you need to move both eyes at the exact same speed as this soccer ball to follow it. And then, of course, while you're following it, if you want to be balanced and not fall over, your cerebellum kicks in. So in something as simple as just moving your eyes from the left to the right, you've just used every single lobe of your brain. And this is why acutely, it's really common to see ocular motor problems after someone's had a concussion. And a test like the King-Devick test, since Dr. Devick is here, is so wonderful at casting a wide net for brain dysfunction, because even though, the saccades themselves, the eyes themselves are okay, the ability for the brain to coordinate them in perfect time is not. And you can pick up those subtle problems on a really sensitive ocular motor exam.
Wow, that's so fabulous. I've never heard it all in one one description like that. And I think, the soccer ball is one, but then the driving home from the game or driving to school. And so often, especially with the high schools I worked, kids were allowed shorter days, but they're driving themselves back and forth, and the car accidents of judging, a car coming at you, it's a car, but you're trying to make a left-hand turn. So, I think incredibly important where that visual part really is, safety at that level.
And that's what concerns me a lot is driving in a lot of patients, because they'll get to somehow they had to get to my exam and they'll get to my exam and I'll do barely making any eye movement makes them dizzy. And I'm like, how are you driving? Because to drive, you need to move your eyes left and right, up and down, front and back. You need to move your head at the same time. You need to interpret cognition. You're interpreting visual motion. And the pathway I just described from the smooth pursuit perspective of tracking a soccer ball is just one of the pathways in the brain. To make an eye movement left to right is a different part of the brain than up and down, and different parts depending on the speed. I mean, the visual system is incredibly complicated for how elegant it is. And driving is a really complicated task. And I'm not against people doing complicated things when they're recovering from a brain injury, but not if it puts them at risk of another head injury or another accident, or they're putting other people at risk.
And especially when you have high school drivers. I mean, if anyone's ever taught their child or someone else's child to drive, initially that, knowing the timing, and knowing when to go. And so I feel like that is one of the pieces that was really left out. Now, I did know for a while that when you were diagnosed with a mild TBI in the military, you had to go and take a driving test with an instructor to get back into active duty. I think they ended up dropping that at some point, but I thought that the military took a better perspective, made it more serious than civilian population.
Yeah, and I pull people from driving for a while, and I think much more than my colleagues for a couple of reasons. So one of the tests that I'll employ is something called the vestibular ocular reflex test, which is read my eye chart while you're moving your head, essentially. And what I find is, you're just shaking it and reading at the same time. And you should actually be able to do it without any symptoms and get to that bottom line. And so the majority of time to drive safely from a visual perspective for our licensure, when we sign off on your licenses, you just have to be able to see 20/40, 20/50, depending on the state that you're living in. And that's without the head moving. And what I have with a lot of patients is if their head's not moving, they see 20/20. And the second they start moving their head, they get dizzy and their vision blurs. And now they maybe see 2100. And I always tell them, look, if you move your head and you see 2100, in my opinion, you're not a 20/40 driver. And usually when I tell them, I don't think you're safe for driving at this time, because again, we can rehab you to get you better. A lot of them give me relief. They're like, I didn't feel like I was safe either. And I'm like, well, then why are you driving?
After concussions, I always called it my return to Twitter protocol, where I could then tolerate a Twitter feed of text going, up and down, how I was using Twitter. That one, it's been a couple of years now, but that was one that was definitely triggered and heals. The one for me that doesn't heal is if there's text and somebody's doing a thing where they're sliding it across. That directional, it literally makes me sick to my stomach. But the up and down I can handle. Is that a different pathway between the two of those?
It is. So if it's still lingering, usually it just means it wasn't fully rehabbed. So in order for people to tolerate visual motion, their smooth pursuits have to be perfectly rehabbed, and their vestibular ocular reflex has to be perfectly rehabbed. If one of them is maybe 80%, it's still going to bother you, usually at higher speeds. And so, and even with my athletes, I have kind of metrics of where you need to meet before I say you're, good to be discharged. And with my athletes, I'll actually increase my metric because I know that their visual tasks and what they're doing are at a such higher cognitive level and speed level than the average person, particularly professional athletes. So, because they have to be able to process their vision while they're running down a field and trying not to get hit by someone else while they're trying to catch a ball. And so their vision therapy is going to be to get you to normal and then to get you back to your beyond normal status that you were before as an athlete.
Well, those slides were amazing. And we already have a series of concussions. And last week we said we would get to a series of questions. Last week we said we'd get to questions, and then we ended up chatting. So Nat Dean asks, 2 points I have questions about. RAPD, relative afferent pupillary defect, being missed in a simple swing test.
Okay. Okay.
See the chat, and then roadside phenomena.
So RAPD, so a relative afferent pupillary defect, for those of you that don't know what that is relative, meaning what we're doing is we're comparing how well does your pupil in one eye constrict to light compared to how the other eye constricts. And so you just literally swing a flashlight left, right, and see if the pupils respond equally. in my experience, number one, this is an incredibly hard test to do on someone after they've had a concussion because they're very light sensitive due to their headache. And so they're just closing their eyes.
Test. Like, it sounds horrible.
Yeah. The other problem too is that most commonly their accommodative dysfunction is all over the place. So the accommodative muscle is also the muscle that helps with letting in light. So you can get some false positives on your RAPD testing because they've just kind of quote unquote blown a pupil because their focusing muscle is out. So that can be difficult. The big thing is if it's a true APD, it's not going to be missed. If it's in my experience, it's not going to be missed because they're very obvious. If it's something that's being caused by something terrible. So in RAPD, let's say that you had a hemorrhage and the hemorrhage is leaking on the afferent visual pathway, which is that blue pathway on the slide of the information getting to the back of the brain. If you had blood impinging on that, the pupil problem, number one, is going to just continue to get worse and worse and worse as the blood pools. So if you miss it initially, it'll eke itself out with time. But what's interesting about the pupils that I wonder with this question about it being quote unquote missed is that there are some really fascinating pupillary studies being done right now, looking at the dynamics of the pupil in concussion, both blast related and traumatic, as well as migraine. And we're finding that the pupils are all over the place in their dynamics. They're too slow, they're too fast. There's a subtle amount of differences in size that are too small for a clinician to see, but they're enough for a machine to pick up. So I think the pupils have a lot to be researched on. So it's a fascinating question, but I think to be determined. Again, like I said, from a clinical perspective, I have rarely had someone miss an APD. But the pupils can do funny things and not be an APD, I guess is where I'm going with that. Roadside phenomena.
Where the brain tries to process everything the eye sees, but the individual is not aware of this, leading to severe fatigue when driving or as a passenger.
Okay. I've never heard it called roadside phenomena before, so I like that one. I call it, I hate the grocery store phenomena. So it's kind of visual overwhelm is the best way to say it.
I call it Costco or Walmart.
Exactly. It's a mismatch between our processing systems. It can come from a variety of different eye movements being awry in my experience. The best example I can give for a layperson would be to understand how the brain processes vision is we have kind of this, it's very oversimplified, but a central process and a peripheral process. So if you're reading a book in a park, the book is centrally focused, perfectly clear, but you're kind of ignoring your peripheral vision. And the peripheral vision is going to be blurry, and that's normal. So if something were to jump out, you're going to move your head to look at what jumped out and change your central focus from point A to point B. So if our saccades, our smooth pursuits, our vestibular ocular reflex is off, and we do that and it gives us headaches, dizziness, nausea, our brain gets into this mode of fight or flight. And so because it knows it can't use your head and your eyes to reflex for you, instead of being able to ignore its peripheral vision, it's kind of like, you know what, we should probably be centrally aware of everything. So it expands that central awareness zone. So pretty much you're paying attention to everything all of the time.
You think it's kind of protective in a way?
Absolutely. I think it's the brain's way of trying to say, hey, I can't ignore my peripheral vision, so let's pay attention to everything. If you're paying attention to everything, you're paying attention to nothing. So I have a lot of patients where you can't find like the milk in the fridge and it's right in front of you. You just can't see it because you're paying attention to everything.
It's amazing. A lot of the, I start to think a lot of the symptoms while the brain is recovering is, has been developed over, thousands of years. Like it's developed, it's appropriate for the brain. It's great for the healing that's going on. It's inconvenient to the society that we're in and what our expectations of our day to day, because it's pretty miraculous, the recovery that happens, but it's inconvenient. So while that process happens,
it's exhausting.
We're fighting the health,
Yeah. And what I found too, so his roadside phenomena, where you're trying to process everything. So that's where you'll get some patients who are like, I can drive on a backcountry road, no problem, but I can't drive in the city, right? Or I can go to a small local grocery store and kind of be okay. But if I go to a larger box store, I have a panic attack. And that's where I honestly think, and I've had a lot of patients with panic attacks in grocery stores, and they're treated with, anxiety meds. And it's not really anxiety. It's just the body's fight or flight response to being visually overwhelmed. And
which again is adaptive, right? The body's actually respond like, this is not working for us. Let's leave. And we're fighting because we really want that thing on sale.
Yeah. Or your family member is like, we've been here 5 minutes, like buck up, you're like, actually, it's a little bit harder than that to explain. But I think it's understanding. Number one, I always tell people is if we can identify the trigger and work on the problem, we can get it to go away. But it's also understanding our limitations during our healing period. And I think that's crucial because in rehab, we desensitize the system with provocation, meaning we're going to provoke your system a little bit, let it recover, provoke, recover. But if you're provoking it all day long, you're actually going to delay your recovery because your system just never has time to reset. Well, and I think going to the store for an hour is a nightmare, and the driving can be awful.
I think there's the part of educating patients about, these are your limitations these are the limitations we see during these phases, but it's actually a good thing because your body's healing and you got to kind of work with this, as opposed to this is a sign that my body is out of control and haywire and broken, when it's actually the body is healing itself. And then we start to fight that. And we have so many questions. Oh my gosh, we may need to go to a little more, we have half an hour. I think there's already 10 questions. So let me move you along to another question from Nat. Always has top level questions here. How often is it not recognized that the Snell chart is not working well for someone who is unaware of their condition and the exam should be moved to a tumbling E chart or pictorial chart? I've had clients where their provider does not go beyond Snell chart, which is very distressing.
I think the big question, one is, I hate to say it, but sometimes it's a time issue or a resource issue. Some clinicians don't have a chart other than the Snellen chart, which is unfortunate, especially if you're working with someone with a higher level brain injury where language gets knocked out and they don't know what letter it is. So sometimes, I'll be honest, sometimes I don't like the tumbling E's because they look so similar that I actually have a harder time with the tumbling E chart than the Snellen chart because of the visual crowding we just talked about. I do use a pictorial chart. So I have a pictorial chart where they can do a matching task instead of having to verbalize it, because some patients have trouble with language and just can't get the language out to say the letters. And it's not that they can't see it, they just can't say it. So sometimes we'll do matching instead. I often find pediatric providers are much better at this because we're used to having kids at different reading levels and having to use different types of eye charts. An adult type eye care provider usually doesn't have other eye charts to even think of using. My other problem with the Snellen chart as well, just from a open access perspective, and why I like having a picture chart, one is it's easy to cheat on Snellen. Like you can kind of figure out what letter it is. Like, yeah, it looks like an 8, but I know an 8 is a B. And so people can say they see it, but they don't. Whereas some of the picture charts we have, like a Leia symbol chart, if it's blurry, it looks like a circle. So if they're constantly like circle, 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 I know they really can't see it. But also unanimously, it helps with different cultures and languages, right? So if you're using the Snellen chart, you're going to assume all of your patients can read English. Maybe they can't, doesn't mean you can't treat them for their brain injury. You need to figure out the system. So I'm also a big fan of having ancillary testing for people who aren't, English speaking or English language.
No, and that's a point, which I'll talk about. An important point. And Hugh Williams came on and talked about his sister who was categorized as, profoundly mentally challenged, and they tested her in English when she only spoke Welsh at age 2. So, the languages that we're using, the cultural of the people that we're testing, and is really important. The next question is, if we've already participated in graduate in vision therapy after concussion, could there be a reason that to need to visit the provider again, especially if another concussion has occurred? Daughter's maintained a concussion headaches since day 1 and has the symptoms that you list. So do you go back?
So I always say, if you've seen one brain injury, you've seen one brain injury, and even within that same patient. So we did my background, which we never finished, which is fine, but I did clinical research for a while at Cal looking at we baselined all the athletes. When they got a concussion, we baselined them again to see the timeline of ocular motor dysfunction, and also to see if it was different from developmental dysfunction. And then if you could get different ones if they've had multiple head injuries. And so what we found was, yes, the ocular motor dysfunction you get from concussion is different from what you had developmentally. And number two is that you could get a subsequent head injury and get completely different ocular motor problems than the first one. So every concussion is different for every patient. So if you've had a head injury and you rehabbed to normal and you got another head injury, you have to treat it like a new head injury. And yes, if it's a visual problem, go back to the vision provider. The other one I've had, and I've really learned so much in moving to this new multidisciplinary practice. We have this excellent cervical PT, and she and I have been learning a lot from each other because a lot of times our symptoms are overlapping with each other. So I find that I can get someone to perfect eye movements, meaning, so the beauty of eye movements, they're objective. So I can tell when they look perfect, but if they're still giving you a headache and the eye movements look perfect, more often than not, there's an underlying cervicogenic headache. And so think of it this way: when your eyes are moving, your neck is stabilizing your head. And so your neck is activated when your eyes are moving, in which case, if they're still getting all those headaches, but the eyes are great, they've graduated VT, cervical PT is usually my next step for people. And sometimes doing them both, because sometimes you have both of those problems.
Yeah, no, that's an excellent and often missed. Martha has a video that appears of someone with impaired vision driving, what lies beneath the concussion.com. So we'll check that out. Cool. Stephanie, in layman's terms, can you describe what other tests could be relevant for someone already in visual therapy who knows vision is central to multiple brain injuries? Are there other tests that if they haven't been done?
Sure. So a big one for me is accommodative dysfunction. Accommodation is the ability for each eye on its own to focus. It's one of the most commonly missed ocular motor dysfunctions in adults, because normally as we get older, we lose our ability to focus and we need reading glasses. So most eye care providers stop testing accommodation in patients when they hit the age of 40. And I've been fighting this for a while within my own discipline, because I have had more people than not graduate from a place come see me and the problem's just accommodation, and we fix accommodation and everything goes away. And the reason is just no one looked because the person was over the age of 40. And I understand from an eye care perspective, educationally, why we don't look, but my adage is, I'm not trying to get someone who's 45 to have the focusing system of a 25-year-old. But oftentimes what I find with the patients that are symptomatic is the 45-year-old has the focusing system of a 65-year-old. And that's why they're having symptoms, is that their focusing system isn't at where their age norm should be. So you're just rehabbing back to where they should be, essentially. So accommodation testing. And for me, a lot of it isn't just like, oh, just near point of convergence. So near point of convergence is a great screener. But I then look, there's 4 different types of vergence pathways. So I look at fusional vergence, I look at vergence facility. So how much can someone cross their eyes and how fast can they do it? So there's a lot of different tests that you can add. I have an eye tracker that I like to use, but again, I like to do it myself. So that's the other thing I've had, where sometimes people will farm things out to a technician, but I want to see, is their head moving while their eyes? Are they, tightening their neck while they're doing it? Are they getting symptoms while they're doing it? Because that can impact some of the results that they're getting. So I have a hard time.
Completely leaning to the side?
Are they leaning to one side? Are they closing an eye? There's a lot to observation that only if you've been doing it for a while, you know what you're looking for. So a lot of it isn't even the test that's being done, but who's providing the test and observing the test while it's being done. I unfortunately, everyone's like, oh, you must have a lot of techs. Nope, I do it all myself, because I'm very big on trying to figure out how they behave while they're doing the test, not necessarily the absolute number they're getting on the result.
Is there a profile? Sorry. Is there a profile of, wow, and I don't, people with lazy eyes? Is there some pre-injury profile? Like vestibular, it's, people that get car sick. Like, is there some profile that when you see in the chart, you're like, we're going to be doing this test?
So for me, it's actually more symptom-based than it is necessarily a pre-existing injury, if so, or a pre-existing condition from an eye perspective, because a lot of, I can link a lot of things to which eye movement is. So when you told me about scrolling, I know immediately it's either smooth pursuit or VOR. If someone tells me I get dizzy and nauseous when I look people in the face, well, we use our saccades for facial recognition. So more often than not, that means you have saccadic dysfunction. I mean, at this point, you can kind of start to correlate the symptoms with the eye movements and figure them out. So I think it's more symptom-based. The pre-injury conditions come in from a rehab perspective, because if someone had a history of a lazy eye, it can take longer to get those patients better. It's also hard because you don't necessarily know where you're going with the rehab, right? I know if someone is normally 20/20, now they're 20/40, where I'm going. Right. But if they've always had a lazy eye, where are we going with this eye? Sometimes can be a little tricky. Having an eye turn can make it a little bit more tricky sometimes. But on the alternative, I've had some people where the lazy eye was helpful because they don't use that eye. So when it turns, they don't get double. So they actually function better than the average person because they're not getting double vision when they should. So sometimes it helps them. And sometimes I know one question is, uncorrected refractive error. You've always had astigmatism your whole life. You can focus through it, but now all of a sudden we need our astigmatism corrected. There's things like that where every case is a little bit different, but I wouldn't say that their condition is, I definitely need to do this test by any means. Yeah.
Someone asked, what helps the most with eye issues where you're navigating through the school hallways without getting dizzy or nauseous? So if somebody comes in and says, I can't deal with walking down hallways, that could be the subway or a school. Is there a angle you go with them?
Yeah. So one is we have to make sure that we're actively doing rehab to get that to fully go away. And in the meantime, it's adaptation. So for kids, when they're in hallways, what I usually advocate and ask if the school can provide is letting the kid either leave a few minutes early or leave a few minutes late so that they can go through the hallway when it's not so visually crowded. It's mainly just a ton of sound, a ton of movement. The other thing that can be helpful for people is, if we're thinking about it as being visual overwhelm, being able to wear a ball cap is super helpful. Think of it like horse blinders. You can kind of turn the brim of the ball cap so that you can cut out some of your peripheral vision, which will reduce the overhead fluorescent lighting being annoying. It will also reduce some of the visual motions on the side, but it'll continue to be a constant problem until you actually rehab the system. So they will need some type of vision or vestibular therapy to get that to fully go away.
There's another question about, are there symptoms or areas that you would like to see cleared up before they come in for an eye exam? I would think if you knew that there was a cervical neck issue, that would probably be like, is there something you're like, well, you'd rather have these things looked at before they come to you?
Not necessarily. I think there are certain conditions that sometimes can be a barrier to rehab. So it doesn't mean you can't see me and we can't figure out what the problem is, which can be helpful because we can talk about adaptations while we wait for the clinician to fix the other stuff. So I wouldn't say it would make me not want to see you for the intake, but it might delay our decision to do rehab. So for instance, migraine, all of the eye exercises so eyes can cause migraine. And so there's a little bit of a battle initially to be like, well, if the eyes are causing the migraine and we do the vision therapy, your migraines should get better. But if you're actually just getting a full-blown migraine, those eye exercises are just going to make your migraine worse. And so migraine for me can be a barrier to rehab, and we have to kind of stair step around those a little bit. So getting migraines treated to a tolerable level is really important. Cervicogenic headache can be a barrier to restoring the vestibular function because you can't do any head shaking exercises if the neck is giving you a bunch of symptoms. But that just means that we start maybe on the eye movements that don't involve the neck. And so sometimes it's just, we change the way we do our rehab depending on what else you have going on. The last one for me that actually is most important is mental health. If someone is depressed or anxious, they do so much better if they get those fixed or worked on, or they talk about it, especially anxiety. And I was talking to one of my favorite clinicians, and he was telling me, he's like, it's not necessarily anxiety so much as he calls it conditioned response. And it's the fact that we know that something's going to make us dizzy. We don't want to be dizzy. We know that we have to do it. And then we mentally overthink it and we become quote unquote anxious, but it's not the type of anxious that you're throwing, medication at. It's actually the learned behavioral response, like Pavlov's dog, that can happen post injury.
Well, and I know especially with vestibular rehab therapy, where people can feel very sick after, and they literally just don't want to do it anymore.
Yeah. I call vision therapy vestibular light. Sometimes you have to go to vision therapy first so that you get the eyes at least better, and it makes vestibular, and then you go back to vestibular PT, and vestibular PT is more tolerable. I've had that for some patients where we just can't tolerate vestibular PT initially. we fix the eyes and then they can tolerate it.
I mean, everything you're saying feeds to the type of practice you're in where you have multidisciplinary team approaches.
Yeah.
You know, which is incredibly expensive. It's and people say, why aren't there more multidisciplinary concussion clinics out there? Because it's incredibly expensive to have all these people around, you know, one patient. So when you have the opportunity to go to one of those places, there aren't that many out there.
Yeah. And well, part of it is also having the disciplines, right? So there's only, if there's not enough, you can have a lot of multidisciplinary areas, but they still might not have every clinician you need for the brain, because the brain does everything. You know, it can involve psych, it can involve endocrinology, it can involve PM&R. I mean, the list is literally, it could be everyone in a multidisciplinary team if you need it.
Here's someone describing their daughter who the eye doctor, she's having trouble with reading small fonts. So he suggested she tried readers, but it made her dizzy. Do you ever recommend, you talked about prism glasses. Do you ever recommend readers for, I've never heard of that one before.
So that's the difference between the focusing system and the eye crossing convergence system. So we call it the near triad. So if imagine you're looking straight ahead and then you cross your eyes inwards, three things happen. So the two eyes obviously cross in, we call that convergence. If that's not functioning, we can use prism for the crossing part. But at the same time as your eyes crossing, each eye also engages its focus so that the image is clear, and then your pupils get smaller. So that's the triad. So it sounds like, just from, obviously I didn't see her, but if she doesn't have double vision, but she has blurry vision, the problem in that triad is either the pupils or the accommodative system. And in my experience, and this is where it comes a lot from seeing head injury versus not, I've argued with a lot of clinicians, accommodative dysfunction in brain injury looks different than accommodative dysfunction in development. And so when a little kid that doesn't have a history of a brain injury has problems with reading small font, you give them glasses and it works and it's wonderful. But in brain injury, what I find is it's not so much that the two eyes can't engage their focus. It's usually a mismatch of the two. So one eye is over focusing, the other one is under focusing. So they're kind of battling it out. And the smaller the font, the bigger the battle. And so you can give someone glasses, but it's going to make them feel worse or disoriented, as in this case. And so rehab is what will get it better. So if the readers are making things worse, then we know that it's most likely, it supports to me that it probably came from the head injury or the brain injury. And number two, that if glasses don't work, rehab is the only option.
Are there any issues that you find with learning disabilities, dyslexia, any type of learning disabilities that you want to know about for the eyes?
I do, because sometimes there's actually a pretty high statistical rate of people having a pre-existing ocular motor dysfunction that is somehow masked as dyslexia or a learning difficulty. And so they had ocular motor problems before the brain injury. Now they have the brain injury, they have more ocular motor problems. And so from a rehab perspective, I think that's kind of like the pre-existing history of car sickness for me. When I hear pre-existing history of learning disability, in my head, I think the statistics like up to 30% maybe is actually a vision problem. In my head, I'm thinking, okay, well, we might have had it better. And so the beauty of that is we still rehab it the same. So once you do the rehab, you know, it's great. But when they're done, if they're like, man, I can read so much better than I was ever able to read in my life before, then they probably had that problem before the head injury as well. Yeah.
Just going through the questions here. And Steve, if you want to jump in at any time as an expert in this field too, and on your thoughts.
I want to ask, can I answer Mark Rosner's question?
Yeah.
That's a great question. So his first, and it's because I've had this topic with a couple of my colleagues lately, is the first question is, how much vertical heterophoria are you finding in your patients? So a vertical heterophoria is a very, very small vertical misalignment between the two eyes. It often goes subtly missed. So, and we were always taught, and in my experience, if you have a developmental one, so you were born with this little vertical misalignment, if we fix it with prism, all your symptoms go away really quickly. I have found a lot of vertical misalignment in my patients with vestibular ocular motor dysfunction. And so I haven't been treating them with Prism because what's been interesting for me is when their VOR gets better, whether it's from vision therapy or vestibular therapy, their vertical heterophoria goes away. And that's very counterintuitive to anything we ever learned in optometry school, because in optometry school, you're essentially taught that if they have a vertical phoria, it's never going to really go away. You're not going to rehab it away. But I found when it comes from the vestibular system, it does go away. And I'm seeing a lot of them. So as far as his second question was, at what point do you consider adding Prism? Again, I do it a little bit differently than how we were taught. And part of that actually was because of the beautiful challenge I got from an athletics department. So normally we're taught when we see an eye misalignment, the first step is Prism, see how they do, have them come back. And if it doesn't work, then do rehab. And that's beautiful unless you're working with an athlete who needs to return to a sport where they can't wear glasses on the field. And so I was given this challenge when I worked in athletics. So let's have you start trying rehab first. And if the rehab doesn't work, we do Prism, which is, again, not how we were taught, but sure, let's try it. And I started that a decade ago, and it's been how I treat patients ever since, because I found that some patients I can get better before their glasses get back from the optical. So I start with vision therapy first, unless they have a very, very large eye turn. So if this is a clinician asking the question, for me, if their eye turns more than a 5 to a 10, I'll probably give a little bit of Prism just to help them come together. So I need them to see single for me to get the rehab to work. So I will give them what I call a little bit of crutch Prism, usually in a Fresnel. So if you're a provider out there, a Fresnel Prism is a temporary Prism we can just stick on your current glasses. And I like that better than grinding in the Prism, because I've had so many cases where their phoria goes away when they've done the rehab. So that way we're not doing a lot of permanent changes in glasses. You put this sticker on, they feel better, we do the rehab, we take the sticker off. So I've been doing a lot more Fresnel for those cases, but every case is a little different. But I actually do a lot less Prism than I think people would think I would.
Mark, did you want to unmic and follow up with that? And Steve, if you wanted to jump in and say anything too, it's great to have you on the call.
Mm-hmm.
Sure. Hi, Jackie. Thanks for this wonderful presentation. My background actually is emergency medicine.
Okay.
So I've done a lot of that. So I've seen a lot of acute traumatic brain injury. And I also work with my wife, Debbie Feinberg, who's an optometrist who's doing a lot of binocular vision work with vertical heterophoria. And we're finding a lot of vertical heterophoria in these patients that are post-concussive. And they can have just this really small amount of misalignment for years. It's not too different than what you were saying. And then we're finding that the small amounts of Prism that we're using, which are really small, like less than a diopter small, like sometimes a quarter diopter small, can make a big difference. And in many instances, it's both eyes that are the problem, not just like an SOP.
Yeah.
And in many instances, there's a vestibular component.
Yeah. So, and that's exactly it. So it often gets missed. It can be a huge cause of symptoms of dizziness, imbalance, and disorientation. So a lot of these people don't make their way to an eye doctor.
Mm-mm.
I don't know if you've ever heard of the condition Malday-Embarkment syndrome, but those patients also have a lot of vertical phorias. And with those patients, vertical Prism does wonders for a lot of them. So I've treated with a lot of vertical Prism, but I don't grind. I usually will always start with Fresnel in these patients, see how they do with it. And if it does seem like it's permanent, because again, we don't know if they had it before the brain injury and now they're symptomatic for it, or if it's new from the brain injury. So if they had it before, correcting it permanently is usually helpful. But if it's new, then I find correcting it, rehabbing the vestibular system, and then taking it away is usually what works just fine.
All right, just curious. Yeah, we're more of a Prism approach as compared to VT approach. But having said that, clearly, there's a place for both.
Well, you can, and the other thing you can do is put them in Prism and have them go see vestibular PT, and then recheck them after they've seen vestibular PT.
They're good.
Mm-hmm.
Jackie, do you have differences between a pediatric and adult, differences between men and women? Is there anything that kind of falls out between the groups, or is it really based on the person and the injury?
It's based for me on the person and the injury. I think we used to say, female versus male from a cervical perspective, but I would just go from the aspect of if you have a smaller neck, you're more likely to have a, cervicogenic component. So for me, I look at that a little bit more. But even that being said, I've had big, bulky football players who have cervicogenic components. So I think there's also a lot to just complaining about symptoms and then having the ability to be accepted to complain about symptoms. So I have a hard issue with saying one gender versus the other, because everyone reacts differently to everything. So I think sometimes, unfortunately, people kind of overlook female symptoms or male symptoms, but particularly if it's a subtle symptom, because in brain injury, it's an invisible disease, right? You look fine. You're just complaining. All I asked you to, you had a hard day. You were home all day. All you did was the dishes and laundry, which, by the way, the dishes and laundry are a very high vestibular oculomotor task. It's exhausting to do the dishes and laundry if you've had a brain injury and you have eye problems. And they get overlooked. And that it breaks my heart. I think a lot of my consults is talking to people about symptoms that they're almost afraid to bring up because they've been told before or invalidated of their experience that whatever they're dealing with is not a big deal. And for me, if it's different from their normal and it's impacting how they do their life normally, it's a big deal to me. If it's a big deal to them, it's a big deal to me. So I think the big thing from a provider standpoint is just listening and understanding that.
And then between pediatric and adult, there's so many different groups within that grouping, but is there a group you see more vulnerable or more easy to rehab or?
So I'm actually doing a clinical trial right now, looking at the impact of vision problems on adults in brain injury. And one of the reasons for it is because I think we don't give enough credit to how much your vision system impacts your quality of life as an adult. And there's a ton of studies on kids. So there's a lot more studies out there in the pediatric group because of sports related concussions than there is in the adult group. I think kids are easier to rehab in my experience than adults because they have an adult pushing them to do the rehab. And also kids sometimes, but not always, get the luxury of getting some adaptations that some adults can't get. Right. So a mom of three kids under the age of 5 can't get a break from that job, and that is going to be a very provoking job. And being a parent is a very under acknowledged task that you have to keep doing. And so it's learning how to live and adapt with that. And kids, I always say kids adapt like the Hulk. So they get better really quickly. It's wonderful to work with them because it is refreshing to have people that just get better in 3 to 4 weeks versus months, which is some of my other patients. But yeah.
And then just last question, is there, any thoughts of what you'd like to see next happen in the vision space, what you'd like to research, or, any thoughts in our last few minutes here that you would like to talk about?
I think for me, it's advocacy of getting a vision exam, knowing where to get the appropriate vision exam, and the advocacy for early intervention and rehab. It takes longer to rehab people when they've been out for the longest time. And I think the biggest complaint that we get in our clinic is, I wish someone would have referred me sooner. And that breaks my heart because it's not hard as a provider to refer someone, right? To just say, hey, you should go over there. And so I think that has to work with education and advocacy so that we can start working together as clinicians to get people a little bit better. And then my big thing is increasing telemed services, because that will also help. Increasing telemedicine and breaking down those barriers of state boundaries can be helpful as well.
Well, that's what I was going to say. So in the telehealth space, how much can be done in telehealth right now in the vision world?
So for me, I can do my entire exam on a telemed platform from an ocular motor perspective. So that part I can do. And I always just say, if you can get a local optometrist or ophthalmologist to do the dilated refraction exam, and I know some clinicians aren't comfortable with that. I'm comfortable thinking that my colleagues can do the eye care exam. I know I'm good at the other part. So that's kind of what I do. My issue has been, because telemed's wonderful and I can treat people through it and we can do rehab through it. But there's a lot of boundaries from my license that tells me I can't do certain things, or I can't see certain people in certain states, or the patient has to be in my state. And that for me is awful because it's a barrier to treatment. And you're telling patients, well, you have to drive into my state to do it. But if they have a vision problem, they can't drive. So it's just a lot of barriers.
I recently had that where they called up, they said that it was okay for me to see an out-of-state provider, but then when it came down to the claims, they're like, well, your address isn't in the same state. Like they're just, the insurance companies are always gonna, so I definitely don't depend on the doctor's office to know all the intricacies of your own insurance, which I'm finding really tough right now. So, well, I really appreciate you being on the call again and all these great questions.
I know we didn't get to them all.
I know we're just going to have to keep having you all back. And just, can you describe the clinic? Because Dr. Wexler was on last week. Can you talk just a little bit how your clinic is set up, and then I will let you go because I think you had a hard stop at 3.
Yeah. So it is a multidisciplinary clinic. So I moved from San Francisco to Virginia to work in this practice because it was just an opportunity I couldn't say no to. So we have the Concussion Care Center of Virginia. So we have a brain injury specialized PM&R, Dr. Zasler. We have an incredible neuro PT who specializes in cervicogenic headache, Dr. Etheridge. And then myself for optometry. And then we also have Dr. Wexler as neuroendocrinology. And so we each actually operate our own practices within this group, which is nice because then we can do whatever we want, how we want to do it, which I think was important for all of us, because I used to work in a system that said you had to see people in 20 minutes, and these are not 20-minute exams. For me, they're an hour and a half. So I like being able to give people the amount of time they need. And I get autonomy through that. But we also get to talk to each other behind the patient's back, obviously with their permission. But what I mean by that is when the patient's gone, sometimes, over the water cooler, we'll sit down as a group and just say, what do you think this symptom is? Do we think we need to start with PT? Do you think we need to start with hormones? Do we need to do all of them? And we have these discussions about the patient, which is helpful for the patient's care, because trying to get a patient to tell another provider something's hard. Trying to get patients on the phone with each other is hard. And so there's this beautiful setup where we're in the same office. If I have a patient that comes in and I think their eye movement problem is more cervicogenic, I can literally walk to the office next to me, knock on the door, and Sarah can come over into my room and do a quick neck screen and confirm for me, like, yeah, it's a neck problem. And then we know it's an appropriate referral. I think what's frustrating for me, for a lot of patients, and that's where PM&R is so wonderful, is knowing who to go to when and where is so hard. And you have a head injury. So trying to be able to know what you're doing is hard. And being a caretaker, there are 1,000 places you could go if you have a brain injury. But do we need to go to all of them? No. Does every single patient need to see me after they've had a brain injury? Absolutely not. There's a very small subselect that needs to see me, but those that need to see me need to see me. And so it's trying to figure out and navigate that space. And I think a multidisciplinary practice helps with that so much.
Well, thank you so much. And I want to thank Dr. Steve Dievik for being here. He is the King Dievik test, and nice to see you, Steve. And thank you everybody else that was here today. I do all the editing. I have a new editing software. People have already asked where Dr. Wexler's was, because I usually put it up right away, and I'm kind of dove a little too deep in editing, but it was really fun. So I'll get those done this weekend, and I'll have last week's up, and then I'll get this one up. So really appreciate you. Next week, we have a very special show. So hope you all tune in again, and really happy to have you. Thank you, Dr. Theis. It was really great to spend another afternoon with you.
Yep, you too. Thanks for the opportunity.
All right. Thank you, everybody. Take care. Stay healthy. Bye-bye.